the full buildup. And we're looking to get your feedback as we seek to finalize the report mid-month here. Like Sharon mentioned, this is all part of the state's broader ABA rate study initiative, where this will be ultimately a report that is shared with the state legislature. We'll also be following up after this call with a copy of this presentation. So this will be made available to you. I believe the state will be posting it on their website. So it'll be available for all stakeholders. So that will be ready for your reference. And then again, ultimately, we will be developing and submitting a report that will have a fair amount of detail, but the themes of which will be consistent with what we're sharing today. If we go to the next slide, please. So again, at a really high level in terms of an overview of the project, I know most of you have been on these calls, so in case you're new to this, just really quickly, as part of this ABA rate study, it's actually a requirement from the state legislature in House Resolution 207. And so this rate study and this report that we're developing, again, will be submitted to the legislature in advance of their 2024 session. And just so you're aware, this is part of a broader initiative by MedQuest to look at a community-based service rate. So on the HCBS side, for example, there has been an ongoing rate study as well, also requested by the legislature. And so this has been conducted in alignment with that separate HCBS rate study process. We go to the next slide, please. To summarize or to describe the services that are included in this, the specific procedure codes that are included in this rate study, you can see the list here. And so these are the various different rate calculations and ultimately what will be included in our final report. And as a reminder, the rates that we're calculating and there are expected funding increases that would result as part of these new rates that we'll be talking about later in this presentation. But because of those funding increases, in order to implement new rates, the state would need an appropriation from the legislature. So just something important to keep in mind is that MedQuest would not be in a position to adopt these rates on their own, that they would need an additional appropriation from the legislature, so it does need to go through that process. The other thing to keep in mind is that MedQuest is proposing, if approved by the legislature, MedQuest is proposing to publish these rates like in a QI memo, but at this time has no plans to direct or require the fee schedule. So it would be published and available for reference by the providers, by the plans, but not a requirement or a fee schedule, let's say a traditional state plan or fee-for-service rate change. It would be something in a QI memo for purposes of managed care. So also something to keep in mind as part of this process going forward. Okay, so hopefully that provides some context to this overall process. What we'd like to do next is to start by summarizing the feedback that we have heard, again, both from these meetings, and we thank everyone for your participation in this process, also for your participation in the provider survey. So we wanted to summarize that feedback from the meetings and the survey, and also, of course, welcome any additional feedback that you have as we walk through this. So with that, I will turn it over to my colleague Dalal, who will walk us through it.
Thanks, Ben. And I'm actually going to take this section.
Dennis. Sorry,
Dennis. Appreciate everybody's time today. I'm going to review the stakeholder feedback and input. At the end of this section, I'll pause to see if there's any kind of questions that you may have. To Sharon's point, you also can put any kind of comments or feedback or questions within the chat too. So one of the core parts of this project has been capturing the current provider experience. And we really want to just be upfront and appreciate everybody's participation in that process. So we had two main avenues to capture stakeholder feedback or input. One was through the provider survey, and the others through the stakeholder meetings, where we discussed aspects of the ABA services that are not easily reportable through a survey. So on this slide is where we have a summary of the provider cost and wage survey. Um, so the purpose of the survey was to capture and collect information on wages, and costs, as well as things like paid time off, training requirements, service delivery time. Um, this was based upon a snapshot in time for certain aspects like wages, reflecting September of 2023. And then other aspects looked at 1 year worth of reporting information, such as your costs. The survey lasted about 3 weeks. It consisted of 8 different worksheets, including one for notes. Um, Overall support had both a recorded training or walkthrough of the um, cost and wage survey, which was posted on the MQD website. There was exhaustive instructions, and then also an inbox for any kind of questions that you may have had. The next 2 slides are going to go over some of the high-level observations. In general, we received 20 surveys. So we move to, thank you. So we received a total of 20 surveys. We wanted to highlight some of the key observations from the provider survey. Again, these are at generally a high level. And then in future slides, we're going to Dalal's going to walk through how these observations helped inform some of the rate model assumptions. Staff information, reported hours. 16 out of the 20 surveys included paid time off information, including both holidays and vacations, with an average of 130 hours per full-time equivalent employee. 18 out of the 20 surveys included training time, which averaged to 93 hours per FTE. And then 16 out of the 20 surveys included client-facing time, which averaged to 328 hours, or roughly 16% of a full-time equivalent working 2080 hours. And then 13 out of the 20 surveys included annual staff turnover information, which averaged a 32% turnover rate. So again, just wanting to bring forward some of these, when we think about the staff and people delivering the services, these are some of the observations that we captured as part of that survey. And again, in the future slides, we're going to show how these inform some of the rate model assumptions. On the next slide, we have provider costs that again were captured as part of the provider survey. And generally, when we look at these costs, we grouped these costs based upon employee-related expenses. So those are going to be things like your benefits, your taxes, 401k. We then grouped it by transportation-related expenses, so transportation related to delivering services, and then administrative and program support. So your administrative overhead, any kind of IT, as well as program support. So any kind of costs required to support delivering of a service. And these costs are generally compared to direct care salaries and wages. For the ERE, or again, those benefits and taxes, providers reported approximately a 22% average percent of costs. Transportation was very small at 0.51% of an agency's overall costs. And then administrative and program support expenses was just over 17% of a provider's or agency's overall costs. So again, we wanted to provide an overview of the values that were reported, and in future slides, we'll dig into the details of what is included within the rate model assumptions. We also wanted to include an overview of the staffing and wage information, and we're going to have a very detailed slide regarding wages. But generally, we found that there is a very low use of contracted staff. there were uh, 2 instances of a BCBAD at a doctoral level being reported, and then 16 FTEs reflecting an RBT. So again, a small amount of contracted staff, and there was wide variability within the rates that are paid for the contracted staff, from $50 an hour to $90 an hour. For the employed staff, there was the most reported instances for BCBAs and RBTs, which, based upon our stakeholder discussion, aligns with the what we would have expected to see. There was less frequent instances of your BCABAs, so your analysts, and as we had mentioned, or as we look at our staff, we saw few instances of BCBAD, so your doctoral level staff were reported. So when we pull this together, this aligns with the information that was also reported of, with less BCAB at the doctoral level. They did not frequently provide the services, and a majority of the services were provided by BCBAs. For the some of uh, the 0632T codes, or that the supporting assessment, we did see that generally had both BCBABs and RBTs. And then generally, when we looked at the direct treatment, the 97153, and the group treatment, we saw a lot of instances of those being reported by RBTs. And also wanted to call out and acknowledge the supervision that is provided under the different services. If you'll remember, and we can move forward. So again, this was a general observation of of the uh, the provider survey results. One of the second part of the stakeholder information is from the stakeholder meetings that we had. So we had a meeting on November 2nd, where we brought forward some of the feedback that we wanted to summarize. And again, these are high level, but also being used to inform some of the rate assumptions that we included. So providers stated that RBTs are difficult to recruit, retain, and there's a lot of workforce competition. Um, while these RBTs have generally had a lot of challenges with hiring and retaining, these have increased since the public health emergency. So there is competition from larger agencies for hiring RBTs, and also in other industries. So non ABA services, and really directly looking at instances of worker burnout. So scheduling challenges, an acknowledgement that the services that they provide are very challenging, and that at a certain point, it's RBTs are looking for a different industry. There's also interagency competition, where hiring bonuses are being offered to RBTs to join a competing agency. There was a feedback regarding the BCBA staff, that they are really important, often homegrown, um, also very difficult to recruit. When BCBAs tended to leave an agency, it would be to start their own. There was also feedback regarding the different billing policies and practices across the payers. We brought forward some of the examples, where one MCO within Hawaii allows billing for an RBT and a BCBA concurrently, while other MCOs do not. One MCO also had a lower assessment, or had an assessment cap on the number of hours that they would reimburse for, which was not consistent with some of the other plans. Some of the other feedback that we captured was regarded the service delivery and staffing. So providers stated that services are reimbursed the same rate for all places of service. So that means that we did not hear that there was a feedback between a clinical or a community-based setting. Providers stated that that the 0362T and the 0373T are not frequently billed, and that is mostly due to the high cost and low reimbursement rate of those services. Providers stated that on average, the supervision time is approximately 10 to 15% of a 15-minute unit. And then providers stated that on average, RBTs have about 1 hour of administrative tasks for every 8 hours of service. So again, wanting to bring forward some of the general stakeholder discussion topics that we had. These are in conjunction with the provider survey, um, some of the major themes that we had provided by the provider experience. So I'm going to pause and just see if there's any additional comments or feedback related to anything that we've reviewed. Okay. I'm now going to go through the comparison rate development approach. What I'll be walking through is called the independent rate model framework. So if we move to the next slide, the independent rate model is intended to be a ground up approach, which means that there are independent factors and inputs that are based upon information that has been reported through various data sources. They are based upon expected resources that are required to provide the service. So they are not limited based upon previous payments or provider capacity. It is really intended to look at the expected resources that are necessary to deliver the services. So this is a common methodology for community-based services. Many states include the independent rate model approach, and has been listed as one of the acceptable methods for rate development by CMS, or the Center of Medicare and Medicaid Services. And Ben had mentioned also that we are going through an HCBS rate study. That also includes the independent rate model, as well as the Hawaii developmental disability rates. Some of the benefits of the independent rate model is that it does include transparency. So each one of the components that goes into the rate model has an independent and transparent factor that is intended to highlight the cost required to provide the service. Because the factors are transparent, they can also be easily updated in the future for rate adjustments and updates. It does facilitate the comparison of actual costs to providing services. So the different, comparing the assumed resources to the actual costs. And as I had mentioned, but there is no tie to the to the costs of delivering services. The next slide is going to go through each one of the general components of the independent rate model framework, and Dalal is going to walk through each one of these. So we have I'm sorry, she'll be walking through each one of the assumptions that we included. So we have the direct care worker and supervisor salary and wages, understanding that the direct care worker from an RBT to a BCBA, including both the direct and indirect time. So the time delivering a service as well as supportive time for things like note taking, prep, and setup. There is a supervisor component. Supervisor component may be the BCBA for certain services. Wages, paid time off, and then also ratio of staff to people being served. The next component is going to be the employee related expenses, which is, as I previously mentioned, and we looked at those values that were reported within the survey. This includes taxes and fees, but also things like benefits for health insurance and retirement contributions. There's also an administrative and program support. So as I had mentioned, these are things like your IT and your overhead costs. You may have things like accounting departments, but these are generally going to be grouping together the administrative and program support. When we look at the potential rate models going within each one of these factors, We're going to just move to the next slide. We mainly looked within 4 different areas. The first is including publicly available information. So when we talk about wages, there's the Bureau of Labor and Statistics, which is a federal data source. That data source does report down to the state level. So wages are comparison at a state specific value. The BLS publishes information based upon a variety of industries, including behavioral health and healthcare, to things like farmers and hotel industry. There's a consumer price index for trending and looking at the how costs have changed over a period of time. And then state-specific wage and labor force projections, which are available to help identify changes in demand. Um, as we spent quite a bit of time, we asked for your feedback. We held, this is our third stakeholder meeting, wanting to capture your experience and understanding of how services are delivered, as well as any kind of components or challenges that you're having with providing services. There's the provider survey, which we had provided an overview of those responses and values. And then state memos and regulations, including Quest integration memos. We also completed independent research through the reviewing the Behavior Analyst Certification Board materials, the ABA Coding Coalition, the American Medical Association, and BCBA licensure rules. So the independent rate model really is intended to look at a variety of different sources to try to help inform assumptions within the rate model. I am seeing that there is a comment in the chat, and I'm going to look, just briefly pause, um, and we will just make sure that we address this. Okay, there's a comment regarding the independent contractors, um, regarding if they are not allowed, RBTs are not allowed by BACB rules to be independent contractors. Thank you for that feedback. Um, and I'm just trying to see if there's anything else and just a due diligence follow up to make sure that providers are following both the IRS and Department of Labor rules. So appreciate the comment. Thank you.
Yeah, and I would just add, and you'll see this once we walk through the rate calculations and the inputs, but our assumption is, based off this feedback, that the RBTs are employees. We are not building rates assuming that contractors are performing that service.
Thanks, Ben. Okay, we're going to briefly move to the next section, and you may see a quick pause on your screen. We're going to pick back up and go through specific service assumptions for the model rates, including provider groupings. So that includes the staff and wage assumptions, a review of the ERE components, as well as the PTO and training and conference time, as well as the administration and program support. If we go to the next slide, though, there are 3 assumptions that we wanted to walk through specifically that are outside of the rate model. But these are general assumptions that we are working with that informed the draft model, informed the draft rates. So the first is that we assumed a combined licensed behavior analyst type, which reflects both BCBAs and BCBAs with their doctor at the doctoral level. This was largely based upon stakeholder feedback, a review of other state practices, and also alignment with the scope of practice for staff that develop and oversee the services. So generally, when we look at the current QI memo, you'll see that there are separate, the BCBAs and the BCBADs are broken out. We have generally grouped them together with under a licensed behavioral analyst provided grouping. The other assumption that we wanted to highlight is the concurrent billing of CPT code 97153 and 97155, which is described as the direct treatment protocol as well as the protocol modification. So the draft comparison rates incorporated feedback from the service providers and other stakeholders on allowing concurrent billing of those two codes. We do want to stress that this is not a policy change, but something assumed within the staffing models of the rates. So this is, again, there would need to be a future policy change, but when we modeled the rates, these are the assumptions that we included within the staffing structure. The third assumption that we wanted to also include and call out is for regarding group service rate models. We provided the procedure codes of 97154, 97157, and 97158, that these do assume adjustments based upon the number of members served. This is a change from the current MQD fee schedule, which for certain group services pays both one-to-one and one-to-two services at similar rates. So this does have an adjustment for group sizes. There's also an adjustment for indirect time, but we wanted to make sure to call out this change as it does shift away from the current structure. So again, these are three assumptions that that informed part of the rate model considered. I'm going to hand this over to Dalal, who will walk through each one of those assumptions.
Thank you, Dennis. So I'll be covering assumptions that are feeding into our the modeled rates, such as the wages, the PTO, the paid time off, and the employee-related expenses that are based on the wages. So to start with, I would like to mention that we have developed two methodologies for identifying ABA staff wages, and we relied on two sources. We relied on the BLS wage data and the ABA provider survey data. First here, I'll cover the BLS wages and the steps that we took to identify those wages. The first step was to obtain the most recent BLS wage data, which was published of this year for May 2022. And I want to mention that BLS does not always publish a specific occupational code that directly matches or corresponds to the ABA staff members that are providing the services. So based on that, we have grouped together relevant BLS occupational codes, and I assigned a wage weighting and blended the wage based on that weighting, based on our understanding of the qualifications of the ABA provider types. So as I mentioned, when for each combination of BLS occupation codes, we refer to those combinations as a provider grouping. And for each provider grouping, we selected a percentiles that it was applicable to represent a similar ABA provider type level for the modeled rates. The third step in identifying the wages for ABA staff is to apply an annual trend factor of 3.12% to the base wages. And this the trending factor resulted in an increase in the wages of 6.9% from May 2022 to July 2024. I'd like to mention that the selection of the BLS wage percentiles and the annual trend factor was informed by the emergent workforce specific wage trend, also informed by the stakeholder feedback that we received through the provider survey and through the work group meetings, and MQD's intent to maintain a strong behavioral workforce in Medicaid to carry out those program goals in today's inflationary and workforce shortage environment. In the next slide, I will go over the second wage data source, which is the provider survey, and the data that we received from providers through that survey. So we followed a similar approach in this one, but we started by looking at the data that was reported from providers, and we compiled and analyzed that data, and we selected the median wage for the assumed wages for the purposes of developing the modeled rates. And the third step was to apply an annual trend factor. It's the 3.12% to the median hourly wages reported. And this, by applying the trend factor, we did see an increase of 2.6% in the wages from September 2023 to July 2024. Overall, providers reported wages for BCBA at the doctoral level, BCBA, and the BCABAs and RBTs. We list here the number of responses that we received from provider surveys, which was 3 providers that reported wage information for BCBA at the doctoral level, 17 provider surveys reported wage information for BCBAs, and 8 provider surveys report wage information for the BCA, BA, and 18 provider surveys report wage information for RBTs. In this slide, we show the provider groupings wage assumptions that feed into the modeled rates for the ABA services included in this rate study. I'd like to mention that we have modeled 3 scenarios for the service rates. And here we show the wage selections for each of these scenarios. First to the left, we see that we list the provider groupings and the BLS occupations that we selected, as well as the wage blend weight. As I mentioned in the previous slides, those wages selected were trended to July 2024. And for each of the modeled rates scenarios, we have selected an applicable wage. For scenario 1, we have selected the BLS 50th percentile. The second scenario of the model rates, we have selected the survey median, and the third scenario of the model rates, we have selected the BLS 75th percentile. For the RBT, we have looked at the social and human service assistants occupation code and the psychiatric technicians. For the BCABA, the board certified assistant behavior analyst, we have selected the substance abuse, behavioral disorder, and mental health counselors, the BLS occupation, and we've assigned 100% of the wage weight to the BCABA. For the licensed behavior analyst, the LBA, we have selected the social workers, all other, and the psychologist, all other. And you see that for the RBTs and the LBAs, they have a mix of 10% to 90% of the wage blend of the selected BLS occupations. I just want to clarify here that what you see here are the assumed wages, what we assume that provider would pay an ABA staff in each of these scenarios for scenario 1, scenario 2, and scenario 3. And later on in this meeting, we can see how these wages feed into the overall developed rates. In this slide, we show a breakdown of the employee-related expenses assumptions, and in here we're using the survey median wages. You can see in column A, we have the trended survey median wage for the RBT, the BCABA, and the LBA. And overall, the ARE percentage is based on the employee-related expenses that are shown here and divided by the annual employee salary. So we do see overall there is a variability in the ARE percentage by the provider type, and that's based on the annual employee salary. Overall here, we can see that the employee-related expenses include the employer entity's portion of payroll taxes, the employee medical and other insurance benefits, the employer portion of retirement expenses incurred on behalf of the ABA staff. And I'd like to mention that a significant portion of the ARE is driven by the cost of the health insurance and the retirement benefits that the employer provides to its employees. Okay, I'll go into the next slide. I will cover here the PTO training time and non-productive time adjustment factor assumptions. We do see that we have them. They're very the same approach was selected for the RBTs, BCABAs, and the LBA. This is assumed by the total hours of 2,080 hours, an annual total hours of the 2,080. For the paid holidays and PTO per year, we assumed 160 hours. And the ongoing training conference time hours per year, we have selected the 93 training hours, which both are somewhat similar in alignment of to the provider survey results. We show the breakdown here for how we calculate the time adjustment factor. And overall, that meant to include an estimated increase for one-time training onboarding and considers the frequency of this type of training that is attributed to the employee turnover. And as you see here, we have a 35% of a turnover rate, which is a bit higher than what we see in the survey results, the average turnover rate. The next assumption that I'm going to be covering the administration program support costs, but first I'd like to go over a definition of the administration and program support costs. So in general, those include the administrative related expenses and the program support costs. For the administrative related expenses, this includes all expenses incurred by the provider entity that is necessary to support the provision of services, but not directly related to providing services to individuals. You could see here is a list of the employee related expenses and the wages that is included under the administrative related expenses, and it ranges from the salaries and wages to training and employee development expenses, including related travel, to board of director related expenses. For the program support costs, this includes supplies, materials, and equipment necessary to support service delivery. In our in our modeled rates, we assumed a single factor of 18%. That is used as an adjustment to account for the cost of administration, program support, and overhead of the provider in the modeled rates. The administration program support components for ABA services assume program vehicle expenses in addition to the administrative staff salary and wages, and to the other program costs that are also considered in the assumed 18% adjustment factor. Overall, the 18% factor is consistent with the ABA provider survey results. I'll pause here for any questions or feedback you may have. Okay. For the next slides, that will go over the calculations of the modeled rates.
Thank you, Dalal. So now we've talked about the overall approach and the different inputs that go into the rate calculations. What we'd like to do is to talk just really high level in terms of some estimated payment impacts, and then walk through some example rate calculations with you, and then we can stop for any questions. So let's go to the next slide, please. So like Dalal mentioned, we have modeled 3 different rate scenarios, and the differences between the different scenarios are all in the assumed wages, like Dalal walked through. So the scenario 1, that's based off of the 50th percentile wages from the BLS. Scenario 2, based off of the survey median wages, the ABA provider survey median wages. And scenario 3 would be the 75th percentile wages from the BLS. So the impacts of using these different wage inputs into the rate calculations range from low to high, all 3 of them resulting in modeled payment increases in aggregate across the ABA services. So we're working with calendar 2022 claims data, and the base payments from that time period were approximately 14.6 million. And so when we model the rates based off of these different scenarios, you can see we model a range of aggregate payment increases that would be as a result of these rates. So starting with scenario 1, we estimate a $3.9 million increase. That would be 27% above the 2022 base period. Scenario 2 would be an estimated $5.2 million increase, or a 36% increase. And scenario 3 would be an estimated $6.3 million increase, which is a 43% increase. So obviously a significant increase in funding. This, again, when we talk about the legislative appropriation and going through that process, this is why that additional funding would need to be appropriated from the legislature, ranging from 3.9 million to 6.3 million, or a 27 to 43% aggregate increase. So again, a very high level, that's what we're modeling. Now, these payment projections assume that as part of these increases, that there would be a change in billing policies that would allow for concurrent services. And the specific combinations you can see there, concurrent billing of the 153 and the 155, whereas we understand today, essentially, the RBT time for the 153 is not being billed separately when provided concurrently. And then the same for 153 and then the 156. So for family training, the assumption here is that that could also be billed concurrently. So we have modeled an estimated increase in service units. And so that is also assumed in these payment increases, these estimated payment increases that you see here. So again, at a high level, those are the estimated payment impacts. And so next, we'll walk through some example rate calculations. There's also an Appendix D, which is included in this presentation, that goes through some rate benchmarking, comparing rates to other payers. And so that has also been part of the analysis and something that we've been looking at. So if we go to the next slide, please. The first example rate that we'd like to walk through is for the code 153. So direct treatment by protocol provided by the RBT. And this is under scenario 2. So that, again, uses the provider survey medium wage. So let me walk through this rate calculation. I know we've talked about some of these inputs, but this pieces it all together. And so we want to make sure that everyone can follow along how this rate buildup works. And if we look at that first column, which is specific to the time for the RBT. So you have a 15-minute service unit, and we then add, in addition to that 15 minutes of billable time, additional indirect time. There's indirect time of 2 minutes, plus some additional adjustments for PTO training conference time. That is an additional 14.7% that's applied. That builds up to a total adjusted minutes per unit of 19.5 minutes. In other words, provider can bill for 15 minutes of time, but we're adding another 4.5 minutes on top of that billable unit as part of the rate buildup. And so you take the total adjusted minutes per unit of 19.5, you multiply that by the wage in row I there, and that gets you to the that wage expense per 15-minute billable unit of $8.17. Now, the column next to this is for the supervisor. So this assumes that you're billing for the RBT, but there's also a supervisor that's also that is included in the rate buildup. And so this is assumed to be an LBA, and so we have in here in row E a span of control or a ratio assuming essentially 6 RBTs for each LBA. And so we're allocating this person's time to this specific billable unit attributable to the RBT. So when you do that allocation, you can see in row H that results in total LBA minutes per unit of 3.25. And then you multiply that by the hourly wage for the LBA, and you have the $3.42 expense per unit for an allocation of the LBA's time as part of supervising the service. And so that's the total wage expense per unit. That's that fundamental rate component related to the labor cost for the service. We then layer on top of that the ERE percentage in row K, and like to walk through, that differs depending on whether it's an RBT or an LBA, different factor. And so that provides an additional rate component, which if you add the two, the RBT, the LBA, and those components together, that builds up to an additional $3.55. And then lastly, we have administration, program support, and overhead, that 18% factor that's layered over the top for an additional $3.32, which builds up to a total modeled rate for the 153 code of $18.46. Again, and this is this medium scenario 2 version of the rate. Again, 18.46, and then we have their comparison of the current RBT rate of $12.50. So, this being obviously the highest volume across the different services, but we wanted to make sure that was clear in terms of that buildup. We have a few other rate examples to share. Let me just stop though and see if there's any questions, comments before we go to the next service.
And I think folks should be able to come off of mute, or you can chat in the chat. Type in messages as well.
Okay. Hearing none, if we go to the next slide, please. So this next rate example is for the 155 code. And again, this is that same scenario 2, wages based on the provider survey median. And so this only has the LBA time, as you can see, just one column there for the LBA time. And like we've talked about, the assumption here is that as part of this modeled rate buildup, that the 153 time, if provided concurrently with the 155, and if that service is provided by an RBT, that could be billed separately. So there's no allocation of RBT costs in this particular rate buildup because of that assumption that it could be billed separately. If it isn't able to be billed separately, then you'd have to revisit these assumptions. But assuming it is billed separately, we're only including the LBA time here. And so it's a very similar concept, assuming one-to-one service here with the total buildup of the 15 minutes additional indirect time that's layered on top. Because of the nature of the service, there's more indirect time that you can see here. So adding up to just over 24 minutes for each 15-minute service. And that gets applied to the hourly wage. And you layer on top of that the ERE component, the admin component, and then that builds up to a total modeled rate of $37.56, a modeled increase you can see there over the current fee schedule rate of $31.25. So that is the modeled rate for direct treatment with protocol modification. We have another example if we go to the next slide. So, and we want to show another example of an allocation of the LBA time in a service rate that has supervision. So this is the 156HN code. So family training, but the assumption here that it's provided by the BCA BA. And so you can see here on that first column, the primary staffing being the BCA BA, and the assumptions around for each 15 minutes, the indirect time, again, assuming just over 24 minutes per unit, the associated wage for the BCA BA, and then their buildup. And then also we have, assuming that there's supervision by the LBA, a span of control of 1 to 6. So one LBA for every 6 BCA BAs and that ratio. And so an allocation of that LBA time that is also included into the rate. Also with the components for ERE and for program support, building up to a total modeled rate under this scenario 2 of $31.93 per unit, which again is higher than the current fee schedule rate of $25. So we hadn't shown a BCA BA rate yet, but we wanted to put that in front of you as an example. And then the last example that we have to show you, now this is not a service that has hardly any utilization today, but we wanted to show this example because this is the 0362T code, the behavior identification supporting assessment, which, as we understand it, has 3 FTEs that would be providing the service, but that the current rate today essentially is, it is the same level as assuming a 1-to-1 service. So we're building in here. You can see across 3 different columns, we're assuming 3 FTEs, 2 RBTs, and 1 LBA, and their associated wages, ERE, and the program support and everything that goes into that. And so all of that is being allocated into the rate, again, building up, assuming 3 FTEs for 1 client, and that service happening concurrently, billed as 1 unit, but the 3 FTEs and those costs being baked into the rate. That resulting in a modeled rate of $57.19 under this scenario 2, compared to the current rate of $31.25. Okay, let me just stop there and see if there's any questions about this approach. So there's a lot of different rate cohorts, of course, different modifiers. We have the 3 different scenarios. So a lot of different combinations or permutations, if you will, from that. But we want to give you a feel for the rate buildup and, again, the different components, the wage adjustments, the allocation of supervisor time, and that kind of thing. And so hopefully that gives you a feel for that. But let me just stop there and see if there's any questions or comments.
When can we expect a confirmation of what scenario is being highlighted to move forward with, or that determination process?
So, and we talked earlier about on the HCBS side, and that process also going on. So as part of this rate study and in alignment with the HCBS rate study, at the request of MedQuest, we have looked at different scenarios. So they have asked for essentially 3 different scenarios. So all 3 scenarios will be included in the rate study. And so that will be made available. And then ultimately the selection of that will be essentially at the discretion of the legislature as to the scenario that they are, that they would support and fund. And Sharon, you're welcome to add to that if there's anything else.
No, I think that's right on target there, Ben.
And then there's a question about when is the legislature meeting, and their session begins in January. I don't recall the exact date, but I believe it is early to mid-January. I don't know about when they're meeting on this in particular.
Right. The scheduling of those sessions, I think, happens as they get started. I'm not sure, but your legislative liaisons are probably much more aware than even I am for the HABA.
Okay. So I see another question in the chat about concurrent billing for 153 and 155. So if we could back up Bilal to the 153 rate. Thank you. So let me just clarify. So the modeling approach assumes that there would be a future change in billing requirements that would allow for concurrent billing for 153 and 155. We understand that that is happening today with HMSA, but not for the other plans. So we are including supervisor time here, but that LBA column that you see here, that is not intended to compensate for the 155 time. That just assumed this is to get the payment right for 153. We understand that there would be there needs to be that supervisor component, and so that's what this is to cover 153. It is not to make up for a lack of being able to bill for 155 and 153 separately. So that's why, and for this one, you do have that LBA component, which, as we understand it, is a requirement. You have to have that supervision for the 153 service. And then on the next slide for 155, yeah, thank you. That's why for this one, there's only the LBA time, because if 153 is provided at the same time as 155, our assumption is that the providers will be able to bill for both. And so there would be no RBT component for this particular service. But you know, the providers will be able to bill both the 153 and the 155. Okay, there's a question about group service rates. So we do not have a slide on the group service rate. That is something that we will be including in the report. I think what I can say about the group service rate is that, and Dennis talked about this earlier, but right now we have a dynamic where, particularly for the 1 to 2 rate, that essentially, you know, for direct treatment by protocol, and then you go from that, the one-on-one rate, to group treatment by protocol. You know, for the RBTs, you're carrying forward that $12.50 rate, right? It's the same thing going from 1-to-1 to 1-to-2. And I think for one of the rates, it actually goes up a tick. That would be the protocol treatment with protocol modification. It ends up going up a tick. And so what we're saying there is that we believe it would be appropriate, especially if the 1-to-1 service rate is going up as part of these modeled rates, that when you go from 1-to-1 to 1-to-2, that there would be an adjustment to reflect and to allocate some of those costs across the multiple clients. I'm not saying that you take the 1-to-1 rate and divide it by 2. That it's not that simple. But the assumption is that from going from a 1-to-1 rate to 1-to-2 rate, that it doesn't double the costs. And we acknowledge it's the cost would be greater than a 1-to-1 service, but it's not double. And so there would be kind of a graduated adjustment to reflect that. But you know, those are there are a number of, like I said, a number of different rate cohorts and details that will be shared as part of our report. There's a question is the indirect time per unit here to adjust the rate for the time that RBTs are getting paid. For the time that RBTs are getting paid, that is not billable. So yes, and I don't know if Dalal, if we could go back, I think maybe there's a couple slides that we could highlight in terms of the indirect time. Yeah, so that there's kind of two parts to that. You can see here that there's training, PTO, et cetera. So there's that non-billable time that we're reflecting, and then there's also some indirect time as well. So again, yeah.
And
Go ahead.
just I was going to say just to as you mentioned, there are two different components, right? So one is kind of in main conference and as well as the time to bring on new staff, but then there's time that is not billable, like note taking, setup, components like that. So and if we go to the rate model, I think you can see that there's a 15-minute unit, and then there's that adjustment for those sort of those more standard indirect cost time that is not billable. So hopefully that provides a little bit more information regarding those two different adjustments.
Okay. Any other questions on the rate buildup?
It looks like we have a question from Jay in the chat. Is there any consideration being considered for a higher rate for in-home and community-based services to compensate for the associated travel costs?
And I can respond and provide if you want to provide anything else. Generally, so there in one of the surveys, and we don't have to go back to the slide again. These will be posted. There was very small amount of travel costs that were observed, but we do know that other states, other payers do have a different rate for community and in-home. There was nothing within what was provided in the survey model to adjust the rates. However, there is a general understanding and acknowledgement that that is something that does happen from other payers, but it is not something that we built within this this proposed framework.
I'd also add that essentially that 18% overhead, when we look at the survey results, that even though the transportation component was relatively small, that it essentially has rolled in that transportation, at least for the amount of transportation costs that were observed. That 18% factor does consider that.
Essentially, if folks are seeing if there's any questions, and maybe there aren't, do we want to start to talk about next steps, and then we can see if there's anything that comes through the chat?
That sounds good. So we'll go to the next slide then. Thank you. So like we mentioned, we will be sharing this presentation. It'll go on the ABA rate study webpage there. And so and a recording of this presentation will also be posted like it has for prior presentations. So all the discussions to date and all the materials that have been shared are available on that webpage for your reference. So we'll give you a chance to digest it and think about if you have any additional comments, because we do need to provide this rate study to MedQuest and to the legislature in advance of the next legislative session. We are asking for a quick turnaround in terms of feedback. And so if you could provide your feedback within a week, so by next Monday, the 11th, we'd appreciate it. And you're welcome to submit it. You can see the email address at the bottom there, hi.aba.ratestudy@milliman.com. And again, we appreciate your feedback. And then as a next step, we'll be working with MedQuest to finalize the rate study report. And as we understand it, MedQuest will be submitting that report to the state legislature for their consideration for the next legislative session that will start in January. Okay, so we can stop there again and see if there's any comments or questions. Again, feel free to raise your hand or enter it into the chat, come off mute. But this essentially concludes the materials that we have to share today, and so we can open it up for any questions. Thank you to Christian and Angie in the chat. There's a question. MedQuest will submit one of the scenarios for the legislature to approve. So the report will include all three scenarios, and I think MedQuest will be sharing that range. But Sharon, I don't know if you have any thoughts in terms of. I think that might be the extent of. I'm not sure that MedQuest is going to be, selecting a scenario in particular, but rather, submitting that to the legislature for their consideration.
You're correct, Ben. That's the path that we'll take is we'll provide them with the rate study that was requested, and they will see what we see, so that they're informed of the different options that are projected. I hope that helps. Yeah. We're not going to withhold information if that's kind of a question.
Okay. Okay. Yeah, and I see there's a question about BT versus RBT, and assuming by BT you mean a non-registered behavior tech or something, but no, it looks like there's a comment about what is allowed in terms of licensure, but it is focused on the RBT rate.
Yeah, and then I saw the clarification from Yahaira, asking more is like if MedQuest would be recommending a particular rate. And I'll just say that we usually don't take that stance. We present the information that's available and then allow the legislators to make their own decisions. But also, I think it also should be said that you can also be present and make your positions known to the legislators as well. So please know that as well. It's a public forum, right? It's for input and consideration. So this you are a part of that as well. So.
Okay. Well, if there's no other comments or questions, again, thank you all for your time and for your participation throughout this process. More to come here in terms of releasing the report, of course, and again, we look forward to your feedback. Again, if you can provide it by next Monday, I really appreciate it. And again, thank you for your engagement and participation throughout this process.
Oh, thank you all.
Right. And thank you to Milliman folks for your work on this. Aloha, folks.
Yeah, thank you so much.